Hey, welcome back to Basically EMS, the EMS podcast for basic EMTs. We have a special guest we haven't seen in a little while. We got Mike today. Mike, you want to tell us a little bit about your EMS background?
Yeah, so I've been a paramedic since 2017. Worked 911 for about 6 years, and then been a flight paramedic for a little over 2 years now, which is kind of crazy to think about.
Cool. You do rotor and fixed wing, right? So scene calls and transfers and all of it?
Yeah, mostly rotor these days, but I've done quite a bit of fixed wing. 911s, critical care. We do a lot of pediatrics, which is kind of part of why we're talking about that today.
Perfect, yeah.
So, yeah.
Mm-hmm. Yeah, thankfully this is not a super high occurrence call generally. I don't know, maybe it's a little higher for you because I'd imagine there's a lot more transfers for pediatrics.
I mean, transfers and when, if some rural program gets a call and it's a kid, like they're, like the comfort level changes a bit. And so we get called for a lot of that kind of thing. We'd probably transfer, I'd say 20% of our calls are pediatrics.
Oh, really?
So, yeah.
Do you think that's, this is kind of off topic of what we're talking about, but do you think that's just because of that lack of comfort with those areas, or do you think they actually need that transport?
I think a lot of it from the hospitals as well, hospitals or from these scenes, it's a lot of lack of comfort, and there's just the resources these days are at the hubs, the big cities. Mm-hmm. And so when you have a pediatric, that especially somebody that has some sort of complex medical history or congenital issue, they're going to have to go to some major hospital. So that's a big reason that we get a lot of those transports these days is I think comfort level as well as just resource availability. So
stuff that normally could be treated at your local clinic, local small community hospital needs to go to a bigger hospital.
Exactly. Yeah. They might be a pretty basic issue, but they have this complex history, so they might not be comfortable treating that patient. And a lot of times it just comes down to education and comfort.
Yeah.
It kind of feels good that that's across the board, that everybody's like kid calls make them a little nervous. Kid-related incidents make them nervous. Yeah. That'll be a good thing.
I still get, it's definitely not going to the routine adult call. It's definitely a little bit more nerve-wracking, but I think as we'll kind of talk about it comes down to really keeping it super basic and remembering your, key assessment concepts and just keeping it down to the basics, really.
And putting in the time, too, which is, if you're listening to this, that's what you're doing, right? Putting in the time to know a little bit more about kids, because you can be scared of something and just be like, I'm not going to think about it. Or you can be scared of it and be like, I'm going to be good at this, and so I'm going to take the time to be ready for it.
Use the fear as a motivator to prep.
Yeah.
The fear, yes.
That's a heck of a motivator.
Yeah, for sure. Cool. So let's hop into it. Today we're going to be talking mostly about pediatric assessment, essentially, not really treatments or anything, because that could be its whole own thing. There are some specific things for peds, but pediatric assessment in some ways is the exact same, in some ways is very different. So definitely good to have a good handle on how you're going to be assessing pediatrics. So one of the first things to talk about when we're talking about pediatrics for assessment is kind of the differences in different ages and kind of those developmental milestones. Because if you know what is normal for a kid at that age, it's a lot easier to assess for. So, and I know, like Mike's not a parent. You've probably seen all the memes of like, how old's your kid? They're 132 months, right? Like, which at a level is, it is silly to go there, but a 3-month-old to a 7-month-old, they're significantly different. And so even having a basic understanding, at least that first year, of kind of like some different developmental milestones every month or two. And then from there out, it's maybe 6 months, 2 years, they get to 3 or 4 or something.
Yeah. I mean, I think just being around kids helps as well. Like I don't have kids, but I've got nieces and nephews. And I think anybody that's watching this from home, if you don't have kids, if you have family members that have kids, it's always helpful. Don't be that weird guy that goes to like the park and, takes notes of all the children and draws pictures. But, if you're around kids, it's, just kind of observe how they act at different ages and kind of watching them as they grow, I think can be really helpful as well. Just how they interact with people.
I think that's an advantage. There's a disadvantage and an advantage to having children in this field because, bad calls are going to make you think of your own kids. I would imagine. I never had that when I was actually in the field. But it does give you the experience of like, I've seen providers who have young children do very well with young children because they know kind of what the normal is, just a baseline, because you're forced to interact with it. You know?
Like little stuff that being like, hey, you like Paw Patrol, or like, like you like Bluey, that maybe if you weren't around kids, right? Like, I had that experience with my kids of like, what do my kids that are around the same age what do they like as this patient? And I can talk, like I can be in that area. Like, who's your favorite superhero? Oh, you like Superman and Friends on, on Disney or whatever, right? Like what you can connect a little bit more if you have that, which is really helpful.
Right. Build a good rapport with those kids, and then the call tends to go better.
Yeah, for sure. So with kids, there's different terminology we'll use based off of the ages, right? So typically we're going to talk about infants, and that's going to be the first year of life. So we have newborns, which I believe newborn is the first month, right? And then
neonate to newborn.
Neonate's the first
day,
24 hours.
Yeah.
How long?
28 up to 28 days
For neonate?
Yeah.
Okay. So I think maybe a little interchangeable
from
then?
full term. So
Okay.
Yeah.
Okay. Yeah. So infant's going to be the first year. And then we have toddler that's going to be like 1 to 3. And just remember they're toddling around, right? They don't walk very well. They're toddling around. And then preschool is going to be 3 to 6. And then we've got school age 6 to 12, and then adolescent is going to be 13 to 18. So like teenagers are considered like an adolescent as far as what we're talking about here. Right?
pretty much adults at that point,
basically,
for all intents and purposes.
Yeah, more or less.
Yeah, depending on the kid too.
Yeah. I mean, depending on congenital stuff that can definitely have a play into it.
Or just genetics. It's hard to eyeball a kid sometimes and be like, that's like my wife had a call. It was like, oh, that's a 14-year-old. It was just a really big 10-year-old. You know, I'm like, it's going to be tough sometimes. There's different factors, genetics, and then heritage can be another, what genetic heritage you have can play a role.
Yeah. I coach my son's baseball team. He's 10. And so it's 9 to 10-year-olds. And there's a kid who I swear is almost as tall as me. He's like 5'7", 5'8", right? Like, and he's 10 years old. So it can definitely play into it for sure.
Did he have like a paper birth certificate that said I am 10 on it?
Yeah. Like the old, like Little League World Series controversies. But yeah, that's one thing that's important to remember is we're talking about these basic developmental milestones and all this stuff. Like there's no like it's not black and white. Right. Some kids walk at 9 months, some kids walk at 18 months, and both of those could be normal. Right. So, but having some basic understanding of like, how should this kid be responding to me is probably going to fit in pretty closely to the ages. And, at the end of the day though, the big thing, like what we're looking for is what's their normal and are they there? And the best resource for that is talking to the family members or whoever's around and being like, hey, is this how they normally act? Right.
Exactly. Yeah. I always watch kind of how they interact when I walk in. We'll get into our, assessment triangle and that kind of thing, but watching how they react when I walk in and also confirming with the parents or family members of, hey, what is their normal? Like that's very important to get early of what's their normal compared to how they're acting now and kind of for their age group as well as how do they interact when a stranger walks in the room with a uniform on? So
or 5 strangers with uniforms and scary looking medical gear that they know, especially the age of like, that person's going to give me a shot. Or like they're going to be scared of those kind of things. So knowing that's really important.
Yeah. And I've talked about it before, but just remember like in this field, this is one where people will hand you their sick kids. Like that doesn't happen often. So if it's one of those where you're like, maybe my partner will be better with kids than I am. Sometimes you have a choice, and it's just, here's the kid and figure it out, sink or swim,
Yeah. Yeah. Sometimes they almost like throw their sick kids at you. Like, I don't know what to do. And as a parent, like, as a parent and a paramedic, it's really interesting how different it is when it's your kid, right? Like, years ago, my son, it was very frustrating for us because he'd been really sick, but it just seemed like a virus or whatever. But he like wasn't really getting better, and he's like pretty lethargic, and so we take him to an urgent care. And I had like looked in his mouth, doing my stuff, and I was like, I'm pretty sure he has strep. And I told the nurses we got there, like, I'm pretty sure he has strep. And the PA or whatever comes in and doesn't run a strep test. They run like influenza and all that. And and I get that. And as a parent, I hate this of like, it's just a virus. Just give him some time. It's just a virus. To me, that's like, I don't know, get out of my office kind of a thing. So we walked away like, whatever, we'll just keep him hydrated and everything. And the next day I'm on shift and my wife calls me and she's like, hey, he's laying on the couch. He doesn't want to get off the couch. He's like super lethargic, way worse. And his temperature is like 104.2, like something super, super, super high. And like from paramedic to dad mode happened then. And like I got on the phone to the supervisor and I was like, I'm going off shift. I don't care what you have to say. Take us down. I got my sick kid, right? Like you're like, and like a little bit of that freak out that parents have for sure. And then guess what it was? He had strep throat, and we took him to the hospital. They gave him, I think, like a steroid or something, and a popsicle, and he started feeling a little better. And he went home, and it was no big deal.
It's probably the popsicle.
It normally is, yeah. But so that's something to keep in mind too. Of like, even people that know when it's your kid, like you kind of lose that a little bit. And so like, that's who we are for people, is like, fix my baby kind of thing.
Yep.
Right. I mean, there's a reason they don't let you treat and transport your own family, depending on your agency, because even in my limited, not kid related, but limited experience with my sister having like seizures, I've seen hundreds of seizures. And then that one was like, what are you doing? Like, I know what I'm looking at, but I'm like, why are you being this way? You forget.
And if you can understand that when you're walking into that call of how they're feeling, right? I think it helps walking into those scenes of having that.
Expecting chaos.
Yeah.
Mike knows all about your partner having a medical emergency on shift, right? Did you have your FTO have a STEMI on shift?
Yes. I mean,
granted, it's not a kid.
On a major holiday when I was like my first week as an EMT. Yeah. He turns the scenario. Long story short, he's a great provider.
He's the man.
The man. We come back from a few calls. And he's like, hey, let's run through a scenario, because I think I was getting ready for my National Registry paramedic, because I was an EMT promoting at the time. And he walks in. He's like, yeah, let's just run a scenario quick. Let's do a chest pain call. I was like, all right, cool. Get the monitor. He's like, yeah, just go ahead and ask me all the questions. I was like, yeah, having any chest pain? He goes, yeah. How long's it been going on? 5 or 6 hours. Taking a couple nitros. It's not going away. I'm like, all right, this is specific. Okay. And then he's like, yeah, just throw the 12 lead on and we'll do it like a real scenario. I was like, all right, cool. And put the 12 lead cable on, like the leads on them, and print it out. And I printed out the 12 lead, and I'm looking at it, and I just look at him and I'm like, is this real? He's like, yeah. He's like, let me see it. And I hand him the 12 lead, and this man is like, he's like buttoned up, doesn't, swear or anything like that. He just looks at it and just goes, and then he says the F word. He's like, God. He's like, well, we should probably roll on over to the hospital. We'll stay in service, like just get some blood work. And it's like, no, we're not going to do that. He ends up going to the hospital, had 2 stents placed that night, came back to work like a week later. Just one of those. Yeah, that was my second week as an EMT. And then, it was comical.
Yeah, that's fun.
He's fine.
That's fun.
Yeah, he's still
kicking. He kept working in the field for a number of years after, right? Like, yeah. Long time, yeah.
True teacher through and through. That's dedication.
And you're like, how did he?
Yeah, I'm like, did he push on something somewhere? Yeah.
Where's the rhythm generator?
Yeah.
Yeah. That's funny. All right, back to pediatrics. So infants, right? So infants, usually little babies are going to be sleeping a lot of the time, right? Wade, having a little baby at home might disagree with this, but typically
on paper they do.
Yeah, in the textbooks they do. In real life, not necessarily.
Eat, sleep, poop.
Yeah, maybe.
Yeah.
This is what it says. I don't know a whole lot of parents, and maybe it's just sleep deprivation, but they're like, oh yeah, my baby sleeps for 15 hours a day. No, that's what the book says.
They're lying. I don't believe you.
So little ones, like less than 2 months, typically, they're not super aware of their surroundings. They're not going to be able to tell you from their parents, right? It's it doesn't matter to them. They don't have that level of understanding.
They just can't see yet. Their vision's not developed at that young age, so they can't recognize facial patterns.
Yeah,
which I imagine is just a horror show of mannequins walking around.
And there might be some recognition, right? Like, so especially smells and voice at that age,
right.
They can typically recognize that. And so usually even like 0 to 2, they should be consolable at some level, right? Mom or dad or caregiver, whoever should be like, oh yeah, normally if I rock them this way or give them a bottle, they'll calm down. And if that doesn't work, then that for them is a significant sign, right? If they are inconsolable at that age, that might be all that we can garner from them as far as what's going on. And so that can be a significant finding.
I think that's the biggest takeaway for that age group is the inconsolability, right? Like a lot of times you throw them in the ambulance, you get them in the like your PD mate or whatever you're going to transport them, or a helicopter that's vibrating. They're going to fall asleep. But if they don't, and they're just still crying and just inconsolable, that's a sign.
Yeah. Something's
You want
for
to keep
sure
it as
going
like simple as possible. So
2 to 6 months is where they start to maybe recognize their caregivers. At least more so, right? Like maybe you can visually recognize, maybe little smiles, that kind of thing, to people that they know are their caregivers. And then this is typically where they'll start to be a little more aware of their surroundings. So loud sounds, those kind of things, is they're going to be maybe turning towards them and recognizing those.
This is also a demographic that's easily distractible. Like if you have the toy in the rig or whatever, this is a good age group to use them with.
Yeah. Old school thing, people would do like the glove balloons and give them to babies. Not really something we should be doing anymore. So you might have seen that before. It's typically not a real safe thing to do, right? Babies and balloons essentially don't go well together because they maybe starting this age, maybe a little bit older is when they just start to put everything in their mouths.
Right.
And so we don't want them to choke on a balloon. So,
yeah,
I know where we all worked, it wasn't uncommon to have like a little teddy bear or something in the back just to pull out and use that, or, find something shiny like on your, your stethoscope or something and let them kind of hold and play with that, distract them with that.
The nitrile gloves also don't inflate as well. I've tested that theory a few times.
As the old school latex gloves?
Yeah, they don't balloon up as well. I've got more stories on that, but I'll leave it be.
That was probably just for your own personal enjoyment, though, on shift, right? You're bored, so you're just trying to make balloon animals.
I was learning,
Yeah.
They will fit over your head, though. Like, leave your mouth out, but,
like Howie Mandel, I think, was that the Howie Mandel thing that he would...
I have no idea.
Yeah, we're not going to get into that. Never mind.
Yeah.
6 to 12 months, this age, they're starting to get mobile, which can be... For a parent, it's really exciting at first until you realize, now, I need to make sure everything's baby proofed because they can fall down those stairs now, or they can stick their finger in the socket, or that kind of stuff.
A lot of the classic, I feel like we see a lot of the traumas when they're hitting their heads on something or falling off of things. It's like that age range for sure.
Which from a statistical perspective, it makes sense, right? The more they're moving, the higher risk of falls and injury. And if you think about old people, it's the same thing. The more they fall down, higher risk of injury. Same with kids. They fall down more frequently.
And where do they fall? They hit their heads because they have those big old
giant heads.
Top heavy.
Those, little bodies. They're bobbleheads at this point.
Oh, for sure. Yeah. And you don't recognize that until somebody says it, right? Like, I remember going through EMT school, and I have 7 younger brothers and sisters, and a lot of them that were still young at that point. And going home and seeing my little siblings and be like, oh, they're not joking. Their heads are huge. Like our heads don't grow very much. Our bodies grow to fit our heads, not the other way around. So they have gigantic heads.
Yes.
The good news, though, is kids fall, but they're falling 6 inches, right? If they're just standing. So they bounce pretty well. And most of their falls were an elderly person falls, they're falling from a full adult height. Right. Little kids fall, it's a smaller fall.
And little kids' anatomy is kind of padding them for it. Like they don't have kneecaps because they fall on their knees a lot, and so there's little nuances that the body's preparing itself for trauma.
Yeah. 6 to 12 months, like we were talking about, become mobile. This is where they stick everything in their mouth. And so they just have a lot of, they're not great with sensory yet. And so the mouth is has so many nerve endings and everything that it's just a good way for them to explore things. And so that's a common thing for kids. So choking, obviously, this is a big age for choking, something to be aware of. And then 6 to 12, this is where maybe they'll, if you take them as a stranger, take them from mom and dad, maybe they're going to start crying, get upset, trying to get back to mom and dad. This is about the age where you'll typically start to see that.
Yeah.
So, you have a little kid that can sit up on their own, expect that a lot of the time for, if they're just kind of limp and mom gives them to you and they're not trying to get back to mom and dad, that's, again, very significant, scary finding for you.
Red flag.
Yeah. Kind of working down toddlers. I don't know if there's any big significance, maybe for speech. I think typically probably around the year mark is where we're looking for some basic speech. and maybe some walking around that point. But I don't feel like that's quite as important, those kind of milestones for us and what we do.
Yeah.
I think most parents, if they're getting those good checkups with their pediatrician, are going to know if they're hitting those kind of developmental milestones. And so I don't think that's quite as important for us as like knowing, how they should be responding to us and those assessment tools, essentially.
Right. Yeah, I think we're really from our perspective, the biggest things we need to worry about is kind of stranger danger type of milestones and how are they responding to us when we walk. If you really want to simplify it, are they alert to our presence? Are they scared of our presence? And are they just completely unbeknownst that we walked into the room? That's obviously kind of the sign we don't want, is that they have no reaction or they just don't care that we're there when they typically would. So to really simplify it, I think it's just what's their reaction when we walk into a room and what is it compared to their baseline?
Yeah, we want them tracking.
Yeah.
This is also the age group where they're eating solids, and so choking starts to show up. If they're, per our notes, molars are not in quite yet. They run the risk of just not being able to masticate their food fully. Yeah, technical term.
You got masticate down, then you couldn't get fully out.
Yeah. Yeah.
Because he's been sitting thinking about it. And all he was thinking about was masticate, but he wasn't thinking about what comes after it. For sure.
Masticate food.
The F was leading you somewhere and you just couldn't figure it out.
Yeah.
So for these little guys, typically when we're doing assessments, we'll start head to toe. One big change is we get to maybe like the school age, or maybe preschool age, is where we start to maybe look for feet up instead of head down. And that's to give them a little bit of time to get comfortable with us when we're assessing off of that age.
Rapport building.
Yeah. So, I mean, I don't know. Is there any other milestones you guys feel like we need to cover? I don't feel like there's that much.
I mean, they're mobile at that point and they're exploring at that point. So dangers, it's the same thing as just when they start walking roughly. But at this point, they've kind of experienced a little life. So they're a little more fearless with certain things.
Yeah.
Yeah. I think it's just understanding that, as they progress and are going to get a little bit older, get into some more things and it's more of like the differentials as we walk in, right? They're going to be putting things in their mouths and choking / poisoning, poisonings and that kind of thing are going to be more prevalent in that age group. And so, I think we've covered it pretty well.
I mean, I don't think we're not going to get into it, but like that also understanding that they have a higher risk of trauma at this age is important, because if we're worried about, getting rid of abuse is something in our mindset, we got to remember that these kids do fall down and hurt themselves. Not to say they don't get abused either, but just something to consider, right? If that's something on your mental when you're on a call, just consider all the options around before you start making harsh accusations.
So let's move down kind of to some A&P differences for little guys. So obviously the big one is going to be the airway. And for lots of reasons, right? We already talked about choking and those kind of things. And respiratory, most pediatric really sick kids are going to be respiratory driven just to begin with. So what do you guys got for differences for pediatric anatomy physiology?
Bigger tongue is a big one. LOL. And then the bigger epiglottis. Their epiglottis is kind of more omega shaped and bigger and floppier, so it doesn't function as well. And they're more anterior as well.
Yes, their airway's more anterior. It's kind of a funnel shaped. So they have a choking point in their airway that us adults don't typically have. And so the airway's going to get smaller and smaller, and then it's going to kind of reach that trachea. So they do tend to have more risk for choking because of their airway, and it can get kinked really easily. Not just from their chin moving forward anteriorly, but getting hyperextended with their neck. So thinking of how we're positioning our patients is really important when it comes to airway considerations for pediatrics. A lot of times they might need that padding under their shoulders, whereas in adults we might put padding like a pillow under their neck or the back of their head. So I think
it's coming back to the gigantic bobbleheads, right?
Yes.
Like just relatively, they might need the shoulders padded because the occiput's so huge on their head that it's going to push them into a weird position or something.
Exactly. Yeah.
And then when they're in that infant stage, their trachea is about the diameter of a drinking straw. So that's, not a lot of room to wiggle around as far as, avoiding kinking. You got to make sure you've really got it opened up well.
Yes.
And then talking about that trachea too, and it kind of being less developed with those cartilaginous rings. So like you were saying, it's easier to kink. And then we might also see that tracheal tugging as the little guys are really struggling to breathe. That might actually physically, where an adult, it's a pretty thick, solid, trachea. Where with kids, we might see that tracheal tugging as they are trying really hard and kind of, I don't know, pinch close is really the right word, but
yeah. You could think of all those muscles pulling that trachea around is kind of what it looks like. That is not a good sign.
No, that's a kind of a real late sign. So, definitely not a good sign for kids. Children are going to have a much higher oxygen demand, which is another thing for us to be thinking about, right? So, again, like if there's one thing I think we could stress here is like really look at the respiratory system for kids, because it is where the pitfalls are for kids for the most part.
Right. Yeah. Big reason I like to explain it to a lot of my students. The reason that their oxygen demand is so high is that their cellular demand is incredibly high. For them to grow, and they're growing every single day for a while, they need to have a high amount of oxygen to continue cell perfusion. So it makes sense if you break it down, right? Like there's an inherent cellular need for the oxygen. It's not just because they're just different.
And if you want to look at it this way, look at their heart rates. Their heart rates are high. That means their metabolic demand is high. And so when you have a high metabolic demand, you're going to need more oxygen and sugar. So I think that's really important to think of with our pediatrics.
Yeah. One difference too for the really little ones is they're going to be nose breathers much more commonly. And so that's important for us to think about if we need to suction the nose or those kind of things. We need to be a little more on top of that than we would be otherwise.
Yeah.
And like any of us up here, we can just blow our nose if we need to. Where little 6-month-old, they can't blow their nose.
Yeah.
3-month-old can't blow their nose. So we might need to do that for them. And you should have a bulb syringe to do it.
Yeah, like RSV season is like a prime example. You can walk into a call and see this kid just struggling to breathe, and they have that snot and just that mixture running down their face, and you walk up, and a lot of places carry, they call little suckers. They're like these little things that attach to your suction device that are made for your nostrils. And so you walk up and either have a bulb syringe or one of those, suction their nostrils really aggressively. Like you're going to make them cry when you do it, but just super aggressive, walk in, suction their nostrils. Don't make them get a nosebleed. We're not going to be that aggressive about it, but really clean out that airway makes a world of difference.
Are those essentially just like a soft French catheter kind of a thing?
They're actually, think of it like a nasal atomizer device, but attached to suction.
Okay.
So it's, what we use to give intranasal medications, but it's going to go the other way, right? And so it's going to suck out all that the mucus out of their nostrils, and do that on each nostril a couple times. Don't want a nasal cannula right away because they're already mad at you. Tape down that nasal cannula. They're going to forget about it within a couple minutes, and it's going to be great. So that's kind of my big, when I walk into a respiratory kid and I see that, that's like the first thing I do. And so it's super helpful.
Yeah.
And the boogers you'll pull out of those kids' face.
Oh, man.
Not to be trifled with.
Yeah.
Do you guys have the nose Frida?
Yeah.
Yeah? Yeah. It's one of those things that seems kind of gross. That's the one where like you suck on it.
Yeah.
But
I haven't used it, if I'm being totally transparent. We have one. We also had an automatic one that is the same essentially idea.
Okay. Yeah. Because we just had the bulb syringe because my kids are a lot older than your kids.
Yeah.
And so we had the bulb syringe, and it just never really worked very well in our opinion. So we got the nose Frida. That thing's money.
And they've changed a lot of bulb syringe designs too. There's a lot of different ones out there now that are smaller, and like we have one that I can't remember who makes it, but it works better than the one that traditional bulb syringe that it's a weird shape. It's almost like an oblong type deal, like a yin yang type shape, like half of it.
Yeah. Yeah. So I mean, clear that nose out. That's going to be really helpful for these. And if you think about the size of their airways, right? The size of their nostrils, it's so small, like it's so easy to obstruct, and you gotta clear all that out. And then another thing is a lot of these kids are diaphragmatic breathers, more so than maybe an adult is. So if you're having anything on their stomach or whatever based off their positioning, that can be really detrimental to them. So you should already be thinking about that for anybody that you're going to put in spinal mobilization, anything like that, or how you're going to have them, secured to the gurney. But especially for these really, really little guys and whatever, like you need to be really aware of like how they breathe and how much of it's going to be, you'll see it a lot with little kids is that belly breather. That's the diaphragm up and down. We need to make sure that we're not putting a strap over their stomach or something and blocking that breathing.
Yeah.
Yes.
And we harp on all the time with adults, we never transport prone, but never transport kids prone. That's not an ideal situation.
Yeah.
So circulatory system, the biggest thing is, and we kind of touched on it already, is going to be the pulse rates. The pulse rates are going to be different. So typically going to be higher, like a brand new newborn, 200 is not outside of the realm of possibility. And I don't think we're going to go over it here, but you should definitely, if you're listening to this, you should go either, I think when you guys were talking about like a reference card that you carry, right?
Carry a reference card.
Or something to have at least a basic understanding of what the expectation is for their heart rates, right?
Yeah.
Yeah, what I used to do is on my phone under like your internet or whatever, I set a favorites tab for a full list based on age group and their vital signs. That way, if we're dispatched out to an 8-year-old, I'm going to be looking that up on the way there just so I kind of know, and then I keep it available just on the off chance.
Yeah. Yep. And then as far as circulatory, kids are the color of their condition, right? If they're having a tough time breathing, and especially that kind of decompensated state, you're going to see that cyanosis. If they're really angry and hot, they're going to be red. And, talking about pale skin signs, if they're in that state of shock as well. So they are kind of the color of their condition. So skin signs are super important. Just right under respiratory, the skin signs are going to tell you a lot about their condition.
Yeah. I like that color of the condition.
Yeah,
that does it really well. Yeah.
I had a bright red screaming baby yesterday, so that
he's like, I know.
They turn red.
So yeah, for circulatory system, pulse rates, have an idea, and this is another thing, and we were talking about this before we started like recording. Like the place we came from, and this is more the paramedic level, right? But the expectation is for you not to know this stuff just off the top of your head because you're probably going to be wrong when you have to use it, dosages and all that kind of stuff. Going through EMT school, depending on what school you're going to and all that, right? Like it's so like you need to come in this, you're going to have a blank sheet of paper to write on and there's no references, whatever. That's not real world.
Right.
And so there's nothing wrong with having some sort of references, right? Like they make little wallet-sized cards with a ton of pediatric stuff on there. Use your Braslo tape to be like, oh, here's what's normal and for these kids and all that kind of stuff. Use your references for these ones.
Yeah, I mean, your phone has all the world's information in it. Why not use it? It's not inappropriate or unprofessional to use your phone if it's something where you really need to look something up.
Yeah.
And keep that open line of communication with family members, right? You don't want to walk in on your phone. Like, hold on. So let them know what you're doing because they understand, but just say, hey, I just want to be super careful and I want to double check my dosing or double check, whatever you're doing. And they're going to appreciate that you're being that careful with their kid. So
for sure. Yeah.
They don't want someone that doesn't know a dose and just doesn't want to question their knowledge. Right.
And that extra 10 seconds can make a huge difference.
Absolutely.
Yeah, especially, some of the stuff is so much more complex with kids, right? Like weight-based dosages are so much more complex.
Yeah.
And so taking the time, I know if my Benadryl is 0.1 milligram per kilogram and Benadryl comes packaged 50 in 1, 50 in 2, whatever, like that's a lot of math you have to do.
Yeah.
And to try to do that in your head is not, that's tough. So
don't be proud.
No. Yeah, your pride could affect that kid. So leave it at the door. Do what you got to do. No one's judging you if you have to pull out your references.
Not a lot of 100-kilo kids running around. No simple math.
I don't know. We talked about it earlier. Kid plays baseball against it. Probably not too far off from it. So
what a unit. Sorry.
It's one of those kids where you're like, why are you not on like the select travel ball? Like he's he's a kid. He's a 10-year-old kid that you're expecting to hit home runs, which is not common, right? Like, man, some kids are just built that way.
Built different.
So blood pressures are going to be really varied for pediatrics. I mean, again, talking about this a little bit before, the common knowledge and what we all learn generally is the systolic, you're looking for the patient's age times 2 plus 70, and that's kind of like your absolute low. But you were saying you guys have kind of a different protocol, right?
Yeah, I mean, that's kind of what I had learned, and then we kind of go off of a 90 plus 2 times their age. So we're really, essentially, you're shooting for a systolic blood pressure of 90, especially in most kids.
So like an adult, essentially.
Yeah, it's essentially like an adult. If you're dealing with a really young kid, which you probably aren't, we take blood pressures on 3-month-olds because we have all that stuff. But for the most part, when I was on the ground, I didn't take a blood pressure if they were under like 2 years old.
Yeah.
So you're going off of skin signs, you're going off of their circulatory signs, cap refill, and pulse rate, SpO2, that kind of thing. But if you're taking their blood pressure, yeah, a good range is 70 to 90. Okay. That's going to be a pretty good range.
Yeah, and that's more the low end, right? So
that's the low end.
We're not looking for that as a goal number. We're looking for it above that as normal.
Yes.
Right. Or even on the ground, like you were saying, I never took a lot of blood pressures on kids younger than 2 to 3.
Yeah. So
it was one of those where I could kind of baseline one based on, if skin was looking good and all the things.
Yep.
Yeah. So circulatory system, I think we kind of have that covered. Neurosystem, I don't think there's any big things for us to talk about.
Big dome, big head, big brain.
Big head, for sure. And then, relatively probably larger brain. And so like you were talking about earlier, higher need for sugar, oxygen, all that stuff, right? And so, but it's kind of stuff we already covered there.
This could be something we talk about here with like infants and fontanelles. Yeah. And that those can be a good sign for like ICP. If you see bulging fontanelles on a kid, that's not a good sign. They got head pressure building. But then inversely, as I've been learning, we've all been taught sunken fontanelles probably lead to dehydration. Well, it turns out kids have sunken fontanelles pretty frequently if they're sleeping or resting, any resting state. So if you're, if children, you're in this field, don't freak yourself out too much if you're like, what is going on with that? Normal, as I found out after I freaked out. So keep that in mind.
See, yeah, that's how it is, right? You see that little thing in your kid and you're like, everything just goes out the window and you're like,
Problem is I know too much. And so I'm just over analyzing her all the time.
I had that thought for a long time, but at the same time, because it's so different having kids, like seeing what we've seen and all of that. But then sometimes I have to like just think back and be like, how many bad kid calls have I been on? Right? Like very, very, very few.
Right.
Like very few. And so relatively everything's going to be good. Right? Like thankfully,
kids are generally healthy.
Yes. But as a parent that has seen sick kids and had to like run pediatric codes and all of that, like it is scary having kids. And that was my perspective shift of like, okay, but I've done this for like 12 years and I've been on like, 3 pediatric codes, right? So, and most of the time it's like some congenital issue that just happens, whatever.
Or some freak accident type thing.
Yeah, I think generally it's like traumas and then, like the congenital. I mean, that's when I think back to most of my major peak calls, it's either trauma or it's something that they had already had going on, even now still.
Co-sleeping was the call that I ran most frequently, unfortunately.
Yeah.
Don't do it. It's bad for your health and your kid's health.
It is. And some people will get really pissed off that you say that. I remember working at the fair, like our department had a big ABC's a safe sleep thing. And so it's on the back of the ambulances around here and multiple departments have a thing. And I mean, people would like
alone back crib.
Alone back crib. Yeah. Alone back crib. Like we would get like heckled. There were people that were like genuinely angry. Like I co-slept with my kid whenever, like, well, yeah, like kids used to not wear helmets when they would ride motorcycles. Right. Lots of them died. You just didn't happen to die that time.
Your survivor bias is showing.
Yeah, exactly. So, it's just crazy how upset people can get about that. But it is not generally safe to do co-sleeping.
I mean, you handle one dead kid in your life and you'll never do it again,
Yeah, for sure. So kind of along with the fontanelles, right? Musculoskeletal system. So kids' bones are softer than an adult's, or they're not, and so that leads to different types of fractures and stuff, right? The green stick fractures are going to be more common for kids. So I don't think that like assessment wise is not going to change anything, just a knowledge thing.
I would say though, as far as like red flags go for if you're, I keep coming back to it for some reason, but panning to like abuse is that clean broken femurs in little kids is not a common injury.
No,
and if that's showing up, you need to have, your head on a swivel and pay attention to the other details because they're going to be there. I've had one call, it was for a 2-year-old who had a fractured femur. And they're like, oh, the 4-year-old tried to pull him out of a crib. It's like, how big's your crib? And they're like, about 5 feet. I'm like, so your 4-year-old reached in there? Like the story didn't line up. And sure enough, we got the end of the day. It was not a good situation. But yeah, that's not a common break. You might even see like sometimes the arms would be one just from people grabbing and pulling. But once again, that's going back to trauma stuff and it's green stick fracturing.
Yeah. It is important to recognize that some things are going to be normal and abnormal, right? Like my daughter's 8 years old. Her legs are just covered in bruises all the time. And that's just because she's just she's a rough and tumble kid that plays on the playground and like she bruises, and that I think it's just that age, because I remember being a kid and my legs were always bruised too, right? So you need to recognize like what would be a sign of abuse, like little school age kid with bruises on their legs that are, you know, whatever, and they're not scared of their parents or anything. They probably just play on the playground or play soccer or whatever.
Look for grass stains, maybe.
Yeah, like those kind of things. But it's different if it's a 2-year-old with a femur fracture or, you know, a little one with that. How is that even going to happen? Yeah, it doesn't make sense.
Really listen to the story. And if you can, like, I don't want to say cross-examine, but talk to the parents separately if they're both there to witness it, because, you know, you just never know. And details that don't line up should be red flags.
And that doesn't mean, you know, we're going into this full investigation when we're on the call, right? We're there for the kid, and it's a delicate situation, and you get what information you can, but then at that point, you got to have, you know, we have to pass that on, right, to law enforcement. Like, we don't want to sit there and try to interview the whole household before we're moving, you know, with patient care. But yeah, definitely something to keep in mind.
At very least, report to the doctors.
Unfortunately, it does happen. So
I feel like a lot of the time that's all you can really do, because you don't have anything concrete. But going like to the nurse or the doctor, be like, hey, this looked weird. Just a vibe check for you to watch the parents and all of that, so they can kind of be aware.
Right, and it's not uncommon for hospitals to prematurely get CPS involved because they'd rather be wrong and have to say sorry than, you know, say nothing, and then a kid ends up going to a terrible situation again.
So for musculoskeletal system, also the rib cage is going to be a little more pliable, and they don't have quite as much fat and everything around their organs, and so that's something to be aware of, right? They don't have quite the protection an adult does, because they have less muscle, less fat, more spongy bones, and so it's not quite as structurally sound as it would be an adult for the thoracic cavity.
And then kind of integrating GI too is that, you know, everything's still large in there, but there are tighter bodies, so the likelihood of multi-system or multi-organ trauma off of one incident is higher. Like if the example I use, which I would never do, but is if you were to hit a kid in the stomach versus hit an adult, the adult, if you're aiming for the liver, you'll hit the liver. And a kid, if you're aiming for the liver, you're going to hit the stomach, liver, pancreas, gallbladder, everything, you know? Yeah. So tighter areas.
And the other big one for kids, the other kind of A&P difference is going to be the skin volume, I guess, the integumentary system, and just the surface ratio of the skin is so much more for kids. And so that can be, an important thing for burns, for exposure, hypothermia, all that kind of stuff. So just keep that in mind for kids, as they have that way higher surface area compared to an adult.
Yeah, so keep them warm for sure.
And they have less subcutaneous fat. So the likelihood of burns being more severe is higher. They're not as well insulated, so temperature control is tougher. They're not really set up for success with a lot of this early.
No, yeah. Have you... Over the winter, were you being yelled at for your kid not having socks on? Yeah. Oh man. Yeah. You know, living in Idaho, it glike cold, and like I put socks on the kid. They pulled them off themselves, and all the old ladies at the grocery store like that baby should have socks on.
Like, thanks, Mom.
I tried. Yeah. I promise I tried.
Yeah. Do you mean the ones in my hands? Yeah.
Yeah, so that's kind of, I don't know, are any other big differences A&P wise that you guys want to?
I would say kids, I mean, we'll talk about it when we get, or if we get into shock a little bit more, but they shunt blood a lot more effectively than adults. So their skin signs are going to be, like you were saying, a huge tell. And it's not only things like pale, there's another sign, mottling, that you'll start to see in these kids, which is an indicator either they're cold or they're shunting.
Let's talk about compensation then a little bit.
Yeah,
sure.
So difference in compensation for kids versus adults. What you guys got on that?
I usually describe it that adults, if you think about it as like a bell curve, adults will they'll compensate, and then they decompensate on kind of a similar, depending on the situation, it's more of a gradual decompensation, versus kids compensate super, super well until they cannot. And then it's just a downward spiral.
Yeah.
Yeah. I mean, I think it's pretty self-explanatory to that. Like, we just need to be able to recognize it early. It's not necessarily going to change a ton of things that we're doing, but just that recognition that kids will compensate for a long time. So if we do recognize those little changes in their mentation, their skin signs, their respiratory rate, we need to start treating that and
aggressively
treating it. So, whereas adults, we might have we can kind of watch that bell curve. Like you said, kids will definitely decompensate very quickly.
Yeah. Kids are a hill adults are a hill, kids are a cliff, essentially, right?
Yeah.
Yep.
So like you guys were saying, it's really important to find the subtleties and to be looking for those. You need to be way more on top of those subtle changes than with an adult. They're just not going to show it to you. And when they do, you're way far behind, where with adults, maybe you have some time to get caught up. But yeah, with a pediatric, if they're showing those obvious signs, like you really, that ship has sailed in a lot of ways.
Yeah.
Like
you're going to have to be
behind.
aggressive with your care.
Yeah. So assessment, let's talk about some assessment tools for pediatrics. Mike, you had a big one that you wanted to talk about.
Yeah, so we have our pediatric assessment triangle, which, everybody that's read the pediatric textbook should have that in their mind. And I call it the everyone assessment triangle because I think everybody gets this. And so, adults, kids, whatever the case may be, when you walk in that door, you're taking in all this information, right? Not just the patient themselves, you're taking in the whole scene, right? What's around you? What's what could this kid maybe have gotten into? What's this, the living situation like? And so you're not only taking what the patient presentation is, you're taking in that entire scene. But the pediatric assessment triangle. So what it is going to be appearance, work of breathing, and circulation to the skin. And so when I'm walking into a person's house or whatever the case may be, I'll look right at my patient. Before I really start talking to anybody, I'm just watching and I'm letting everybody else kind of bring in their bags, bring in our equipment, kind of get set up. And I'm just watching the kid. I want to see, are they looking at me as I walk in? Are they crying? Are they laying, kind of flaccid on a bed? Is the parent holding them and they're kind of limp, or are they just moving around and inconsolable? You're just looking at how are they interacting with their space. Then looking at breathing, do you hear any loud breathing sounds, which is, obviously not a good sign, any adventitious type sounds.
Which with kids is grunting is a big one.
Grunting, coughing, sneezing, if they're crying, crying baby's a good baby to a certain extent, right? And then circulation, what does their skin look like? You can see somebody's color of their skin, like their skin signs from across the room as far as pale or normal skins, even some cyanosis. So those are the things that I am looking at for 15, 30 seconds. This is a time to really take in a lot of information while other things are going on. So it takes about 15 to 30 seconds, I would say, before I move in to actually doing things that are hands-on. And so, but I do that with everybody, especially with kids. It's super important.
I feel like especially for students that are kind of in the skill sheet knowledge, right? Like this is just a really thorough general impression.
Yeah, very. Yeah, that's a good way to put it.
It really is just a visual check, but actively doing a visual check because, and especially as you start to get some experience of this job, like you're doing, like you said, this isn't everybody assessment triangle.
Yeah.
We're doing this for everybody, but maybe not in an active way. And this is more to take the time to be active about like, what did the skin look like? What is the, like the activity levels, all of that kind of stuff. Like we're just forcibly thinking about and giving yourself some time to see, because there are some subtleties that you're going to have to look for, like interaction with parents and or responders and those kind of things that are going to be a little bit different that you'll have to really sit back and look for that you wouldn't otherwise.
Right. Yep. You also kind of get your hints at your ABCs just by paying attention. Take that extra 30 seconds. If they're pale, you can assume circulation's bad. If they're screaming, crying, well, baby's breathing and airways open, right? Like you can get a lot of information, like you're saying, very, very quickly.
Yeah. Yep. And this is also time to kind of start gathering, like, how quickly do we need to move, right? Is this something we walk in and we're like, oh, yeah, this needs to progress right now? Or, okay, let's calm everybody down a bit. Let's do some things right here and then kind of get that call moving. So,
and that's one thing that can be nice about a pediatric, where an adult, right? Like if you have those alarm bells initially, it's like we got to get a backboard or scoot stretcher. Like a kid, like I'm going to pick you up. I'm walking you to the ambulance.
Walked into a call before, seen a sick kid, and like, yep, let's go. And like you're moving right away. Hold on, I got to adjust that. There we go. So there are definitely times where that is necessary.
Yeah.
Or
if you're on an ambulance, don't be surprised if you show up and the fire department's there first and you have a firefighter running at you with a really sick kid, or like a code, holding the kid doing CPR as they run out to your ambulance. Yeah. That's another common thing.
I've even had parents too, like same thing, like we're rolling up and as we pull up, dad comes out holding this kid and then I get out and he just plops the kid in my arms. Like, okay, well, this is not a good situation. We got to move.
Yeah. Yeah, so transport decision can be a little bit different and usually easier.
Yeah,
here.
you're
Maybe not transport decision, but the mechanics of the transport side of things can be a little bit easier. Well,
logistically it can get tough with like whatever equipment to get ready.
Yeah, and we'll talk about that later of like how to safely transport a pediatric.
Right.
But yeah, that decision can be a little bit easier to get him out to the ambulance. So the assessment triangle is kind of like a general impression, right? And then ABCs. What's some differences for ABCs that we need to be? Anything specific?
Brachial pulses, depending on the age.
I would argue like really little kids, even a brachial or femoral pulse can be hard. Listen to the heart.
Yes.
That was something that I learned.
From the really little ones, yeah.
Yeah, I learned in my OB rotations in medic school, right? like, there was a newborn and I went to like find the brachial. And the nurse is like, that's never going to work. Especially they're so fast and they're commonly irregular for like brand new babies. Yeah. Like it's so hard. But if you can just put your stethoscope right over that chest and then count, listening to the heartbeat, I feel like the first couple months of life, that's a lot easier.
Yeah, that's fair. On that same note, like if we move to breathing, they're breathing fast. Some of them are belly breathers. They're not chest rising. So I used to just lightly put my hand on them, obviously not hard enough to impede that diaphragmatic movement, but you can count that way as well. Because trying to eyeball a kid breathing is tough.
Yeah, a lot harder than normal for sure.
And then exposing, so like you do your assessment triangle, right? And then you move into your ABCs. You can get a lot about your airway, just kind of how they're positioned. Like if they're crying, they're moving their head around, their airway's open and patent. Listening for that stridor, obviously, especially in their kids, if they have a foreign body or, we think of that croup epiglottitis type situation. So listening for those lung sound or those upper airway sounds. And then exposing, looking for their worker breathing, right? The retractions, tracheal tugging. Seesaw breathing, if they're a little older, is not a good sign right after a few months.
Accessory muscle
usage. So exposing their chest and stomach is really important early, as well as listening to their lung sounds there. And then you can get a lot of information on their circulation. And then it's, just cap refill. Or if, I've used the forehead before on cap refill for those little kids. So you get a lot within those first 30 seconds after your pediatric assessment triangle by exposing that patient and kind of doing a really thorough physical. And at that point, you have most of your information, right, of what you're going to need. Vital signs are going to be kind of secondary, but it's your primary assessment is extremely important with kids.
Yeah, and then remember with lung sounds, they're more anterior. So usually in adults, we preach listen to the back for the best sounds. Kids for sure listen to the chest around armpit level.
Yeah. And then you touched on it, but cap refill is going to be huge for kids.
Yes.
Especially when they're little and we kind of talked about it earlier, but if you can't really get a blood pressure, realistically, they're fighting you, they're moving around, they're screaming, they're crying, all that, right? If they're really little, cap refill gives us more or less that information. We don't have a number, but we have a green light or red light, essentially.
Cap refill is very important in these.
Yeah. Anything else for assessment for little guys? Just some kind of basic overarching things.
We can talk a little bit like blood sugars as well. If we're talking about normal vital signs within our assessment, we did talk about the normal ranges. Getting a blood sugar at some point can be really important in a lot of our kids. And I think we had a note in there of doing anything painful last. That's not the thing you walk right up and like trying to assess a kid, getting the blood sugar right away. But do your assessment triangle, get your primary done. Treat any life threats right away. Obviously, this is, it's no different than an adult. If you see a life threat, we need to treat it. And, but then, something like a blood sugar can come after your assessment because they're not going to like you. You should poke usually their heel. I usually do a heel.
Yeah, for little guys, it's typically a heel poke.
And it's a good rule out for lethargic kids because kids get lethargic when they're sick. Even talking about your son, right? Like lethargic is sick, but like lethargic can be a sugar. I found diabetes in a 3-year-old who no prior existing condition, same thing. Double check because, not always going to be one thing or another with kids, especially.
Yeah. I feel like most of us that have done this for a while we can't diagnose like diabetes, but had that kid that you walked into and they're like hot to the touch and they're breathing fast and they're a little lethargic and you check that blood sugar and you're like, oh, that reads high. Mom, dad, are they diabetic? Like, no, like, oh, this might be a new onset thing that we actually found and you can pass that along. So, always always have your antennas up for that kind of stuff.
And then keep in mind too, is that if you're going to do BG as a painful procedure, that their response to that can be telling too. Because if you poke a kid and there's no response, something's off.
Yeah. Yeah. Or even just before, if they know it's something that's going to hurt, what's their response to that? Like if they see you, if you're wiping their foot with something and they've had their shots, they probably know that's going to be a bad thing. And now they're going to be like looking for mom and dad or, kind of scared. And if they're just chilling, that might not be a good thing, right? They should anticipate something at that point.
Yeah.
So definitely make sure it's kind of the last thing you do, right? Because, you don't want to have that be how you start the rapport with your little pediatric patient. And
you touched on it too, but remember with kids up until I believe it's school age per the book, it's foot to head, and then you can start head down assessment. But build the rapport early because not every kid's going to like you, but if they like you a little bit, it makes it a little bit easier.
Yeah. Another thing with assessment too is probably around school age, maybe a little bit like preschoolers is where they start to really think about modesty and those kind of things. And that can be a really big thing for kids too when we're talking about assessment, right? Like a 1-year-old, you lift their shirt up to listen to lung sounds. They don't care, right? But maybe like a 6 or 7-year-old, they might not be comfortable with that. And so those are the things you need to be talking through and preparing patients for, the little patients. Right. Which kind of jumps into the next thing, like communicating with kids. What do you guys have on that? Any tips or tricks?
Don't lie to them. Kids are really good at reading through bull. They are better at adults than reading the micro expressions in your face. So they're going to know you're lying to them. And, just keep it honest. Obviously, some things are going to go over their head depending on the age, but keep mom and dad involved because remember, they're going to be your lifeline. They know this kid, you do not.
Yes.
And even if you could lie to them about like a painful procedure, like
they're going to find out.
They're going to find out, right? So, like I always like oversell and underdeliver with pain and those kind of things, especially with kids. And so like, oh, that wasn't too bad. Yeah, you're so tough. You're strong like a superhero, right? Like, and you can like build them up a little bit.
Definitely build them up and definitely talk through things with them and make a little game out of it if you can. And incorporating parents, I think is. We were talking about again before this. Incorporating parents is everything. One of the first pediatric calls that I ever went on, we show up. This kid's unconscious in his front yard, was playing. All of a sudden, it becomes unresponsive. We get there, we start talking to him, and he's kind of coming around. And we basically determined it was a febrile seizure, right? Which is so common that we go on. But I had decided this very quickly. Oh, this is a febrile seizure, not a big deal. Talking to the patient, thinking I'm just rocking this call. And my preceptor kind of takes a look at me, hey, you got to talk to the parents. And the parents are sitting there just like, what is happening? I didn't say a word to them the entire time. They think their kid's dying. I'm like, oh, it's fine. This is what I'm seeing. This is what I'm thinking is going on. And just the relief washes over them at that point, right? And so incorporate your parents. I talk out loud as I'm talking to my patient, like I'm talking to the parents at the same time. I'm just incorporating everybody into the assessment, into the conversation, into the entire plan, and allowing them to have some choice. Like I'm leading them a certain direction, but I'm allowing them that choice of what to do with their kids because you don't want someone to walk in and say, this is what needs to be done to your 5-year-old kid, right?
Yeah.
They may not like that necessarily. So incorporating the family into the entire assessment, letting them make an informed decision, but also kind of leading them a certain direction if you feel like they need transport or a certain treatment pathway.
Yeah, just keep them in the loop. Like it's the same thing as with adults. Like if you find a STEMI in somebody, you don't be like, I know something you don't know. Like make sure you're involving them because like you're saying that when it's their kid too, they're going to be, I don't want to say more irrational, but probably a little more irrational because your brain shuts off in certain regards.
And kind of in the same vein to me, like, you don't need to necessarily, or we may not have the ability to like ask permission of the kid for procedures and whatever, but like, make sure that you're incorporating them in decision making, right? Even little ones, maybe not, not a year old, but like a 3-year-old, like kind of talk them through what you're doing and prepare them. And like, obviously we can't be like, hey, do you mind if I stick you with a needle? That's not going to work. But like, explain to them why you're going to do it, why you have to do it, and it's just to make you feel better and whatever, and like make them involved in their own care. I feel like can go really, really far with these kids. Little kids want to feel big. And if you can make them feel big, they're going to like you a lot more and they're going to trust you a lot more. And it's the same thing, kind of communicate to them while you're communicating to the parents. They're like, hey, can I talk to your mom real quick about something? Hey, question to mom, and then back to kid, whatever, right? Like, have that get everybody involved.
Yeah. Right. And you're going to get your history mostly from parents on, especially before that preschool age, toddler kind of age, you're going to get most of your history and information from parents. And then once they're a little bit older, the kids can at least tell you what they're feeling, and don't forget to account for their feelings and what they are presenting with, because they can tell you what's hurting, where it's hurting, and that kind of thing as well. Yeah,
that's a good segue. I was going to bring the same thing up of like when they hit a certain point, remember, don't just ignore the kid and talk to patients or to the parents either. You want to make sure that, especially if they can, if you ask them a question and they're old enough to be able to contextualize and understand and give you a good response, include them in their own care. Yeah. It goes a long way. I also used to, is distraction stuff. Like I've had the kids listen to their heartbeat through the stethoscope. One EMT partner that I had, I used to give the kid a flush and be like, when he opens that door, let him have it. And that one, like he was good natured about it, and he knew that I was probably going to do it if it was a kid too. Yeah. But every time he'd be like, "Wow," and sell it, and the kid would laugh, and that's the best one. Transition to the hospital, like this is about to suck. Let's get a laugh out, and now
let's get the doctor when they walk in the door.
Now anyone you see, hit them. Yeah.
Yeah, but I didn't tell you to do that. Yeah. For the doctor, that was not me.
He reached up and grabbed all those flushes. I don't know.
Yeah, it was weird.
It's crazy.
So, assessment, we've got some assessment stuff. Now we decide we need to transport, right? So, first thing on transport is going to be transport decision. And this is something to always be thinking about. So much of this is going to be knowing your local area and what your capabilities are and what you have around, which, it's different for flight than ground, right? Yeah. But, we're lucky because we're in the big city here. And we have a pediatric ER, we have a pediatric trauma center, we have all of that here locally. But as you're going through all this, think about like, where do I need to go to get this patient the care they need? And sometimes bypassing a hospital, go to a pediatric hospital, if you're in an area where that makes sense, is what you're gonna want to do, because that's just patient advocacy, right? Like you're getting where they need to go without making, a big long delay, and now parents need another ambulance bill because another ambulance is going to have to come and take them, and when you could have gone 10 minutes down the road to the correct hospital. Right.
There's definitely a balance to it, because the area I work in, it's 25 minutes to one hospital and 45 to the other, and via flight. And that doesn't, the 45-minute flight has a lot more capabilities of the trauma center, the pediatric center, right? It's understanding that just because they're a kid doesn't mean they need to go to the long distance hospital and bypassing another one. So you have to understand, how sick your patient is and what's appropriate, not just, let's just go to the pediatric center every single time. So be a patient advocate. If you don't think they need to go to the specialty center for the longer distance and that cost that is associated with that, obviously, take them to that other hospital that's fully capable of taking care of that patient.
Yeah, if you need to stop and get a patient stabilized, stop and get them stabilized, and then likely you're going to transfer them out anyway.
Yeah, you might end up taking them later, but that's okay. They're going to a good hospital still.
Yeah, no, but like to Chris's point and to your point, if the kid is, you've got a little bit of time, everything's going okay, it makes no sense to stop, stabilize them somewhere that's just going to transfer them out anyway. May as well just go to where they got to be.
Yeah.
And this is another time too to maybe use your resources. You can definitely call the hospital.
Yeah.
And be like, hey, here's what I got. Do you guys think this is appropriate for you, or do you want us to go to the pediatric hospital or whatever, right? Like, sometimes, and I've probably said this on the podcast before, right? Like sometimes when we're training EMTs, we don't tell them that medical control is not just mother may I. It's also like, it's general also your phone friend sometimes about like, hey, I'm not sure what's going on with this. And again, like we talked about, right? Like leave your pride at the door.
Yeah.
Like it's okay to call and be like, hey, I've never been on this before. I'm not really sure what to do. Do you want them here? Do you want me to take them to this other hospital? And, I've done that with stroke patients before, and I've had very appreciative doctors like, hey, no, I'll take them here, but, hang out because we might have to transfer them later or whatever. Yeah. Like generally they appreciate that you are thinking that far ahead and that you're doing that for your patient.
Right.
Yep.
In my experience because I've called medical control for kids before, and I'm like, can you tolerate this at your hospital? Most of the time, like, no, just go to the ped center, just go. And, that's an answer too.
Yeah.
It's not always a great one, but it's an answer.
It's the same as like when you bring a 36-week pregnant woman into the ER and they're like, oh, go to L&D, go to L&D right now, go to L&D.
You're not about to deliver.
Yeah. Which, fun fact for our system, any pregnant woman 25 weeks or greater went straight to L&D. They didn't stop in the ER. Found out when a gal had kidney stones, who was pregnant. Also, if that's the case and it's middle of the night, make sure you have a way in and out. We got stuck between a set of double doors for like an hour, just slapping the glass, like, someone let me out of here. Because it was all badge in and badge out. Yeah. So keep that in mind.
Yeah. Yeah, it's always fun. Yeah. So the mechanics of transporting kids are way different, or can be way different than, kicking the table.
Sorry. Big feet.
Than transporting an adult, right? Because, and like, old people like me, like, learning was like, yeah, just put the kid on mom's lap and all that's cool. And like, no, baby becomes a missile that's gonna, run into the back of the ambulance doors or something if that happens. So, I know we have all worked in the same spot, and we had something called a PD mate, which we would strap to the gurney, and essentially was a child seat that was strapped to the gurney. Have you seen any other, now that you've kind of expanded your horizons?
So we have the PD mate as well, but it's like 10 to 45 pounds, I think, is the weight, and it goes down to 4. So if they're under 10 pounds, which happens a lot, you need to add padding to the PD mate.
Okay.
So padding under the shoulders, usually kind of keeping their airway positioned properly. Before going forward with any of these things, always transport your pediatrics within an approved device,
yes.
PD mate, some sort of commercial. If you're working in an ambulance, you have one. There's no that has state mandated everywhere. So use an appropriate device. Try your best not to put them on the patient's parent, like a mother's lap or anything like that. It's sometimes approved depending on where you work. But so there's the PD mate. There's also a thing called a neomate, which is essentially for neos, so neonates and just older than that. So that'll go kind of up to that 10-pound range. They have different sizes of that. They have a thing, I think it's called the NeoFit. It's like a little neoprene that I've only used it once, but for basically newborn infants, and it keeps them kind of snug.
Like a little kangaroo carrier.
It's like
thing?
a kangaroo carrier. Yeah, it keeps them all snugged up, and it has a little ball cap that you put on them, and it just kind of keeps their head in a neutral position. So there are a lot of different commercial devices. This whole roundabout way of saying, be really comfortable with what you carry and train with it. Because you don't want the first time you use it to be, oh, this baby just popped out of mom on the bathroom floor and I'm using this. That happened to me. And we're trying to use this new device after we just delivered this baby on a bathroom floor that we didn't know was going to be delivered. So train with it, practice with it, be really comfortable with using it in different settings. And then, just like muscle memory with everything. You got to don't just train on it until you get it. Train with it every 3 months, 6 months or so you have that muscle memory associated with it.
To kind of piggyback that, I mean, I had a critical call for a 3-year-old, and it was the same thing of like, you need to train with it yourself because you can't always rely on others, because it was, I had never used the PD mate before. So it was like, here you go. And then the fire guy looked at me like I just handed him a human head. Like, so yeah, make sure you're aware, because then the last thing you want is whoever's in charge of the care to be like, oh, hold on. Now I got to, stop this and focus in on that. And it causes problems.
Car seats are also approved in certain agencies. I'm not a huge fan of that as well, because if you do have to manage an airway or something like that, it's hard to have to transition to that, especially if you're in a helicopter or something like that and you have no space. So I'm a big fan of putting them on our pediatric approved transport device on our bed, because then you can really manage that patient.
Yeah, I mean, I like the car seats, but that's usually like,
it's a judgment call. If they're like
based
fine,
off the kid,
then totally.
Yeah, and that can give them their level of comfort. Hopefully, I mean, some parents you'd be shocked at the parents that don't have their kids in car seats and whatever. But little 3-year-olds just not in car seats, but they should have like an approved car seat for their weight and their height, so it should work appropriately. And then again, if you have the ability to, I would take some car seats and practice strapping them to your gurney.
Yeah.
But you can put the head up on the gurney, and now it's just like a normal car seat, essentially, or like a back seat of a vehicle, and you can put the car seat in there like it normally would be and strap it in, and it's going to be exponentially safer than just on mom's lap or anything like that.
I had a scenario like that not first time, but like we had brought a patient in the car seat, and me and another firefighter were like, don't know how to. So we just strapped it in, and the captain walked in and was like, "You guys clearly do not have children. That is so wrong." I was like, "Oh, I don't know. I'm figuring it out." So yeah, practice if you can, for sure.
Yeah. And then one other option that I've seen in most ambulances I've worked on is the captain's chair in the back.
Yep.
Typically it can fold down, and now it's not going to work for a 1-year-old, but if you have, a 6-year-old, now they have kind of a 5-point harness that's going to fit a kid that age.
Yeah.
And which is really good because some things we need to, it's very common for us to not just have to bring one kid. We might have to bring brother, sister, because if mom's at home with 2 kids, dad's at home with 3 kids, whatever, like they're not going to be able to leave the 7-year-old if they have to take the 2-year-old. So there's been a lot of times and we're not going to put a 7-year-old in the front seat of the ambulance. It's not safe. So, might need to think about how else can we safely transport not just the patient, but siblings and whatever in the back as well. And so I've done that multiple times where baby's on the stretcher and big brother, big sister is in the captain's chair, and we have mom on the CPR seat on the other sides, and everybody is safely secured like they should be in the ambulance.
Yeah, logistically, kid calls can get difficult for that reason on top of not only patient care.
Yeah.
I think that's a good segue into like parents and transport as well. I don't know what your guys' thoughts are. I typically, if I can get away with it, have the parents sit in the front seat of the ambulance, just if they're a critical patient, right? And then if it's a kid that's very stable but very upset, I'll have the parent in the back.
Yeah.
That's the kid can still see their parent. But in general, if I even think that this kid is critical in any way and I'm going to need to do some things and there's potential for decompensation, I put the parents in the front seat. And they can still talk to us. We can still kind of tell them what's going on. But if something goes south, I don't want them in the way and having to witness all that like front row seat, right? So that's kind of my thought on it.
Yeah.
And always take the parents if you can.
Yes, 100%. Yeah. I would in general agree with that for sure. The stable kid having parents back there can be really helpful. But, if we're going to have to like do an IO and drill the kid or something like with the flip side, like as a parent, I don't know, man. If I had a really sick kid, I would fight you.
I'm not going to fight them on it. If they want to sit in the back, I'm going to let them know, hey, and I've had this happen, like, hey, can we sit in the front seat? And they're like, no, I really want to sit in the back. Like, okay, but if we have to, start an IV or, do certain things, you're going to have to be there. Or I might have to just tell you to sit right there, and you're going to have to watch everything that's kind of happening. So it's, again, keeping them informed. And if they want to sit back there, by all means, like that's their kid. I'm not going to stay in the way of them and their kid. So,
Which I've had the inverse when I was talking about that femur fracture. There was mom on scene, and I said, do you want to go with us to the hospital? I'd prefer you be back there. And she's like, nah, I'll just meet you there later. It's like, that's a red flag,
for
right?
sure.
Like if they're not wanting to get involved with their kid, that feels weird.
Yeah.
Yeah. Definitely.
And sometimes you're going to transport without parents. I mean, that's a different case, but just logistically, right? Like,
we do it all the time.
Yeah. I'm waiting for grandma and grandpa to get here to watch my other kids or whatever it is. Right. Or, you go to a school and you can only talk to parents on the phone because they're so far away and they'll meet you at a hospital. So it is not uncommon to take kids without a parent there. But if you do have the parents, kind of keep them in the loop, see what they want to do, and work the best with them that you can.
On that note, too, remember, depending on your system, depending on your state, school officials can act as a guardian if need be. I've had that a couple times where it was, mom and dad's unreachable for whatever reason. It's like, we need some variation of consent. You guys are technically the guardian at this point in time, and that will work as well.
Yeah.
That's a good point.
Yeah. So anything else on transport? We are past the time we were shooting for, past an hour. But
I think the only thing really is pediatric equipment versus adult equipment. Just knowing that there is pediatric equipment, pediatric nasal cannulas, non-rebreathers, pediatric BVM, obviously the big one. Practice with all of your equipment. Be very comfortable with not only where it is, because it's going to probably be in a different location than your adult stuff, but practicing on how to use that on different patient sizes. Because, a toddler is going to be different than that 1 month old with all the sizing. So not only knowing where your equipment is located, but how to use it on different size patients is super important.
I'd say kind of the same vein too. You should have a Braslo tape or something similar.
Yeah.
Practice it. Take it out. Get comfortable with it. Because if you've never used it, like, where do I measure from? Which side do I use? Like, get that out there, because that thing is golden, right? Like, having that information is golden.
Yep.
Especially if you're somewhere that parents aren't accessible to be able to tell you, like, oh, a patient's weight is this, or they're this tall, or whatever. Being able to kind of measure that out and have that, and I know where we worked before, right? Like, we had a cool pediatric bag that had different colored bags that matched the Braslo tape sizes. And so if the kid was a blue, we just pulled the blue bag out and it had the appropriate sized equipment. Yep. So, and I imagine, having worked other places, that was not the case, that we had that set up, but, it should tell you what size OPAs, MPAs to use, all that stuff. And so it can be really, really helpful for sure.
Definitely. Yeah, just know your equipment.
Yeah, I was going to say the same thing. Generally, be familiar with your pediatric bag if you have one.
Yeah, for sure. Cool. I think that's all the time we have. We had some other stuff we were hoping to get to, but Mike, we'll just have to. Yeah, that just have to be a part 2. We'll just have to get you back to talk about actual pediatric treatment and the different common issues that we see with kids and all that kind of stuff. So
there's a lot.
There is a lot
for sure.
Subject.
Cool.
And we just scratched the surface, but yeah.
We did. Yeah. This is, there's a reason there's pediatricians and like people that specialize just in kids. Right. And there's a reason there's critical care transport units that are specifically just for kids and all that kind of stuff too. So yeah, definitely not comprehensive, but hopefully if you're watching, listening, it's a good refresher or a good start on some of this information for you. So Mike, thanks for being here.
Thanks for having me.
We'll get you back again.
For sure.
Thanks for listening, watching, whatever. Make sure to hit subscribe, give us a thumbs up, all that stuff. If you have any other subjects you'd like to hear us talk about, we love a comment as we're trying to figure out the next thing to do. We love to hear what people want to hear from us. So thanks for being here, and we will catch you guys on the next one.